Good afternoon, everyone, and welcome to the Lynn Cancer Institute, our physician panel series. Today's topic will be Let's Talk About Lung Cancer, a community conversation, and it really is. We will be learning from our amazing speakers today, Dr. Samuel Richter, radiation oncology, Dr. Samuel Cariff, medical oncology, and George Van Wee, manager for the Tobacco Cessation Program at AHEC, which is the Area Health Education Centers. We're very fortunate to be joined by not only two of our physicians who work with our lung cancer patients, but also George, three experts who are deeply committed to improving the lives of our patients and our community. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, the expertise of our staff, and as we're seeing today, the benefit of our multimodality method of treatment, all combined will truly save lives. In the interest of time, our speakers' bios were sent to you by email. During their presentation, we invite you to please take notes. And if you have any questions, please put them in the chat box or the Q&A box, and the speakers will be able to address those questions at the end of their presentation. We're very proud to welcome you to our Lynn Cancer Institute and to introduce our first speaker, Dr. Samuel Richter. Dr. Richter?
Thank you, Jan, and thank you everybody for this opportunity. I'm going to be talking a little bit about lung cancer in 2025 with regards to radiation therapy, but also a little bit on lung cancer screening. So I have no disclosures, and as many of you already know, lung cancer is quite prevalent. It's the most common cancer worldwide. It's the most common cause of cancer death in both men and women, unfortunately, with about 1.4 million diagnoses per year, greater than 200,000 cases of lung cancer are diagnosed in the USA per year. It results in more death from cancer than colon cancer, prostate cancer, and breast cancer combined. And most patients diagnosed are greater than the age of 65. As many of you know, non-small cell lung cancer makes up the majority of lung cancers. Adenocarcinoma and squamous cell carcinomas, the more predominant histologies, with small cell carcinoma making up about 15 to 20%. And for our purposes today, going to focus more on non-small cell lung cancer. As we all know, risk factors for lung cancer include smoking, which are related to about 80% of cases. Cigarette smoking is the most common cause of lung cancer. It's estimated to cause about 80 to 85% of all lung cancers in the United States. Smokers' risk of developing cancer is 10 to 30 times greater than that of a non-smoker. All forms of tobacco use, including pipes, cigars, chewing tobacco, can cause cancers of both the lung as well as the mouth. An ounce of prevention is worth a pound of cure. So stopping smoking is quite important, not only for patients that are already diagnosed, but patients who are high risk for developing lung cancer. Other exposures and risk factors include the environment, radon, asbestos, nickel, cobalt, cadmium, air pollution. All these things can also contribute to lung cancer. As far as screening, the U.S. Preventative Task Force recommends that for people at high risk, yearly lung cancer screening with low-dose CT can reduce the risk of death from lung cancer. Those that qualify are patients between the ages of 50 and 80 with a history of greater than 20 pack years of cigarette use, smoking now or currently having quit within the last 15 years. And what this entails is going for a low-dose CT scan, which a patient lays on a table while an X-ray machine renders 3D imaging using a low-dose amount of radiation to make a detailed picture of the lung, which you see here. And in this case, you see a small little lesion in the left lung. The scan only takes a couple minutes. It's not invasive, it's not painful, and insurance will cover this if you qualify. How do we stage lung cancer? It's quite complex, related to both the size of the primary cancer within the lung, where the cancer is located within the lung, has it invaded any other adjacent structures or organs, has it spread to any lymph nodes nearby, as well as if it has developed or spread somewhere outside of the lung. For the purposes of 2025 and the newest staging manual, um, the AJCC has broken down N2, mediastinal lymph node involvement, into a single station versus multi-station N2 disease, which has some implications in how we treat patients and what we would do surgically. As far as radiation is concerned for early stage lung cancer, we think about stage 1 and select node negative stage 2A patients. We know that early stage lung cancer, if untreated, has a poor prognosis. Make no mistake about it, surgery, either a lobectomy, taking the entire lobe of the lung, or a wedge resection or sublobar resection, is curative and considered standard of care. But of course, in patients who are inoperable, those that may be older, who have poor cardiac function or lung function, or those who just straight out refuse surgery, very targeted radiation called stereotactic body radiation therapy, or SBRT, can be a highly effective alternative. For patients where their cancers are located on the periphery of the lung, we think about sometimes between 1 and 5 treatments of radiation. For those that are more central, closer to the esophagus, the heart, the mediastinum, we think about breaking it down into maybe 5 or even up to 15 treatment sessions. And the data would say that SBRT might actually be non-inferior to surgery for even patients who are candidates for surgery, though some of those studies that have assessed this have been incomplete, and you can't make that statement definitively, though we do see a lot of folks who, for whatever reason, don't want surgery or actually can't have surgery. What you see in the picture here is an example of an SBRT plan for a patient. You can see the color wash or the dose cloud of where the radiation is being delivered here in the right panel, where the radiation is actually really sculpted around the cancer with this SBRT technique. At the Lynn Cancer Institute, we have one weapon in the arsenal called the CyberKnife. It's the M6. It's the latest model of this kind of machine, which actually has the ability to track a tumor in real time, or even track a small marker that's implanted within a tumor, so that we can be spot on in our treatment delivery every day. Each treatment with this machine might be somewhere between 30 to 45 minutes, so pretty quick, pretty efficient. And again, a patient may be done within a week of treatment. This is an example of a case in which we had a patient with about a 3 centimeter tumor in her right lower lung, treated on the CyberKnife with SBRT for her stage 1 cancer. The radiation came in from multiple different angles using the CyberKnife machine, really sculpting the radiation around the tumor. And what you can see here is her scan registered with a PET scan, the different colored lines representing the radiation dose, which you see really does fall off in her lungs and really does not touch her heart in any meaningful way. And what you see is about 2 years later, that tumor has essentially gone away and evaporated and flattened. So just an example of the type of treatment that we would give versus surgery. Another weapon in the arsenal or tool in the toolbox is our MRI linear accelerator at our Delray Beach office. Also a great machine for delivering SBRT. Since this machine constantly takes an MRI as the treatment's being delivered, it ensures great treatment fidelity between the plan and what's actually being delivered. It actually allows the physicians to adapt and potentially replan a patient in the event of any motion or change in anatomy when the patient actually finally starts their therapy as compared to planning. It reduces the dose of normal tissues such as healthy lung and heart, and it can allow the visualization of the tumor in real time to make us very confident that we're hitting the right spot. This is an example of a patient who had a lesion posteriorly just above her diaphragm, which you can see on the panel on the left. She was treated on her MRI Linac for her early stage lung cancer, and you can see that her tumor was shrinking even about 8 weeks after her therapy. So very, very pleased to have this available to us at the center as well. For stage 2 node positive or stage 3 patients that are more locally advanced, there's a whole menu of options depending on the patient's fitness, depending on their operability, and just generally for patients who are inoperable with locally advanced disease, concurrent chemoradiation, concurrent radiation with chemotherapy is the standard of care. For patients that are more frail, we might try to sequence this differently, in which we may start with chemotherapy or radiation, and then think about adding in the opposite therapy later on. For patients that are surgical candidates, these days we tend to think about preoperative systemic therapy with or without postoperative radiation therapy, which may be an option for some select patients, obviously meeting some criteria for surgery. And for patients who may be surgical candidates where we might be able to convert them to a surgery later on, or for patients with superior sulcus or Pancoast tumors, we think about preoperative chemoradiotherapy as well before an operation. For the locally advanced patients, really upfront multidisciplinary consultation is really important when considering how best to manage these patients, as not every patient's a surgical candidate, and the therapy and the sequence of therapies may be more nuanced. For patients with more advanced or metastatic disease, the stage 4 patients, radiation really fits in terms of palliation, which can be used in the prevention of symptoms such as pain, bleeding, or lung obstruction when a cancer is blocking the airway. It can also be used in the cases of more limited metastatic disease, such when a patient might have what we label an oligometastasis, maybe 1 to 5 spots outside of the lung, whether it be in the bone or the liver or somewhere else. Radiation therapy to those local spots can render a patient potentially disease-free for some period of time. And on that note, for patients that are currently on systemic therapy for their metastatic disease, if the medicine's working everywhere but a couple spots, we label that oligoprogression, and radiation may have a role in bringing the patient back to disease-free by addressing maybe 1 or 2 small areas, which you see depicted here. I'll just say that lung cancer management, as I'm sure Dr. Cariff will allude to, is quite complex these days. We're in an era of precision medicine and targeted therapies, and by knowing the specific type and the molecular signature of the actual lung cancer, we can actually match the right drug therapy to the right tumor, and this allows for better outcomes, more tumor-specific treatment. And the pie charts you see here are dizzying, but they are the alphabet soup of what we're dealing with in lung cancer, which further begets the need to really send patients to multidisciplinary teams. With regards to radiation therapy, I'm happy to report and update the group that proton therapy is coming to LCI in the spring of 2026. You can see from the map on the left all the various proton centers that are currently in existence in our country. Florida has several, and little old Boca Raton is going to have one early next year. And what you can see on the right are the updated pictures of our proton build out taken yesterday during that nice crisp fall day. So very excited about this. I'm often asked about the role of proton therapy for lung cancer. And I think it's worth mentioning to the group that what's so special about a proton beam. Proton therapy, everyone should know that there's a sharp peak in the delivered dose, followed by a rapid fall off known as the Bragg peak, which you see here in this pink line. When spread out over the range of an actual tumor or over the actual cancer, we create what's called a spread out Bragg peak, so that the radiation itself is falling into the tumor and not into healthy structures. Um, this allows for obviously better treatment delivery, getting the high doses where you want it within the tumor, but also sparing entrance dose or even exit dose so that we're not within normal cells. And this is compared to an X-ray or photon treatment, which tends to travel. Obviously, this is a crude diagram. Our photon planning is quite significant and sophisticated. Where a beam just doesn't pass through like this, we take advantage of different angles, but a proton therapy beam does have a potential unique advantage. And in lung cancer, it's currently being studied and was the recent subject of a phase 3 clinical randomized trial, the results of which we're waiting for, but definitely holds a lot of potential for our patients at LCI and for lung cancer patients around the world. Just an example of what a treatment plan might look like, proton therapy versus photon therapy. Here's an example of a lung cancer that needs to be treated in this region, the red being the high dose cloud of the radiation, and the blue and the green being the low dose. What you can see from a photon plan, you see a lot of spray of dose all around the lungs, hitting more of the top of the mediastinum, whereas with protons, you get a lot more lung sparing. And here's just a little cartoon of a lung, but you can see where the star is. Not a lot of dose, if really any dose is treating this opposite lung in this patient. Similarly for the heart, we see heart sparing with such a large treatment field where the low dose is not really exiting nor entering in that area. I think, proton therapy may have some continued role in the management of lung cancer patients who need postoperative radiation. Rare, but it happens when we might find positive margins, extranodal extension, incomplete lymph node dissection, or when our surgeons find something wrong or concerning at the time of their surgery, we may be asked to give some postoperative radiation therapy. And here's three examples of a 3D dimensional, more crude radiation plan versus intensity modulated radiation therapy in the middle panel versus a proton beam, maybe one or two beams coming in, really sculpting the dose around the tumor such that much of the lung and the heart is actually being spared by the uh, proton beam. And techniques like this apply to virtually all disease sites in all parts of the body. And we're excited at LCI to be exploring proton therapy for our patients, literally with all cancers. This is just an example of some data from Penn actually showing dosimetric reductions in both the heart as well as the lung with the proton beam. And lastly, I'll finish by giving a plug for our multidisciplinary team and our lung cancer group, saying that decisions about lung cancer are best made in a multidisciplinary fashion in a clinic with a tumor board, because lung cancer management really is a team sport. We work with a tremendous group of physicians, social workers, nutritionists, dietitians, pathologists, radiologists, and then obviously the oncologists in the group to really try to tailor and make the best decision for each individual patient. I think this is what separates us from many centers around the country. And if anybody's interested, this is the contact number for our thoracic MMC, should you or a loved one need an opinion. And with that, I'll turn it over to Jan and our next speaker. Thank you.
Thank you, Dr. Richter. Dr. Cariff?
So thanks Jan for organizing this. Thank you, Dr. Richter, for an excellent introduction. I'm very honored to be here today to speak to patients and caregivers for one of my dedicated medical oncology expertise areas, which is that of thoracic oncology, also known as lung cancer. Lung cancer is a various disease. There are actually multiple subtypes of lung cancer for which we don't have a lot of time to go into the nuances today. But what we will explore in great detail is how complex this disease is and how much advancement we've had in the past really 10 years in terms of identifying patients with precision oncology approaches, similar to those that Dr. Richter was introducing in our last slide deck here. I just want to add one more point to the kind of great care that we're able to deliver at the Lynn Cancer Institute. Not only is our multimodality clinic, of which we shared a photo just a few slides ago, able to deliver really synchronized multidisciplinary care plans for patients with all stages and types of lung cancer, we actually are cutting edge when it comes to opening clinical trials in this area as well. And I'll go ahead and explain a couple of those as we go through our slides here in the next few moments. So thanks again all for joining. Let's go ahead and advance. Okay, so Dr. Richter and I did not plan this, but I'm not surprised that we actually ended up picking one of the same images to kind of discuss the advances in precision oncology as it comes to patients with lung cancer. I want to focus on the more common type of lung cancer that we call non-small cell lung cancer. It's literally defined by the lack of a very aggressive form of lung cancer we call small cell. And within the 5 to past 10 years, we've seen that there's just been an identification of at least 14, if not more, FDA approvals as it relates to targeted and immunotherapies that patients may be eligible either in the early stage or in the metastatic stage. And we heard a little bit about how patients are divided into those two categories based on their presenting symptoms. So I want to first start with a mutation called EGFR. This is a mutation that is not always seen with patients who have a common risk factor of tobacco use. And indeed, we're actually finding that it has a lot to do with possible family history, such as inherited genetic variants in a subset of patients, also with exposures to things like occupational inhalants, that sort of thing, as well as air pollution as well. And for patients in both the early stage and metastatic setting, we have targeted approvals for oral therapies, such as a drug called osimertinib or Tagrisso. And we're learning that this mutation is actually extremely complex. We can even go down to the submutation in this EGFR family. For instance, there's a submutation called exon 20, for which we have a targeted therapy called amivantamab, which is an IV bispecific antibody, as well as a brand new FDA-approved targeted therapy. It's an oral pill, somatolimab as well, which is very exciting. Next, I'll mention a very common mutation called KRAS, of which there are, again, multiple submutations. The specific isoform we call G12C has two current approvals for targeted therapies called adagrasib and sotorasib for patients in the metastatic setting after they have had disease progression on frontline therapies. And what's very exciting, and in fact, we actually have a clinical trial here at Lynn, is looking at expanding these RAS inhibitors in other sorts of situations. So, for instance, in the early stage setting, we're trying to see if novel inhibitors, such as a drug called olmorasib, so not FDA approved yet, but a clinical trial we currently have here, can be used to enhance outcomes for patients with this mutation. You'll also see in the two yellow arrows on the right side of the screen here for other RAS mutations such as HRAS, NRAS, etc. We're looking for a novel type of therapy, targeted therapy, a pill that can target all of these RAS mutations all at once, not just that G12C of the KRAS that I mentioned earlier. So a lot of understandable interest and research is going into this area currently. The next one I'd like to talk to you about is called ALK fusion. ALK is similar to the EGFR mutation, such that patients with this mutation do not often have exposure to tobacco and indeed have a lot of those occupational environmental exposures that I mentioned to you previously. There are multiple targeted therapies approved for patients with this ALK fusion. Some of the more common ones would be alectinib or Alkenza, lorlatinib or Lobrema, et cetera. And there are multiple trials looking at novel ALK generation inhibitors that can be offered to patients with this mutation as well. And indeed, we have this approved in the early stage setting after definitive therapy, whether that be surgery or chemoradiation more recently for the past few months. The next one I'll mention is this one called ERBB2, also known as HER2 colloquially, based on how it was discovered scientifically in the past 30 to 40 years. You'll notice that there's two arrows here, one for amplification and one just for mutation. And indeed, this has to do with the way that we discovered this HER2. For patients and caregivers on the phone who know of people who have been diagnosed with breast cancer, you might have heard of HER2 in this setting, where patients who have overexpression of this protein are candidates for targeted therapies like Herceptin, Perjeta, etc. But in the lung cancer space, we've also noted that patients, according to a new pan-tumor approval by the FDA in the past couple of years, can be candidates for a novel antibody drug conjugate called Enhertu or trastuzumab deruxtecan. And this is for patients with all types of tumors, but especially what we see in non-small cell lung cancer, albeit given at different dosages. But it's not only patients with amplification. We can actually have just straight up mutations in the gene for which patients can be candidates for this targeted therapy in HER2, as well as a brand new targeted therapy approved in just the past couple of weeks called zongertinib, which we've also seen patients have some good outcomes for, that was presented at our recent ASCO and World Conference of Lung Cancer meetings just a few weeks ago. The next one I'll mention is another double whammy. You can see on the right, two arrows went up for one MET amplification and one for MET splice. And what we're looking at here is another protein called c-MET, for which we can have multiple ways of seeing mutations. One more commonly seen is called MET exon skipping 14 mutation, often seen with patients with tobacco exposure in the previous years before diagnosis. And we do have two FDA approvals for oral targeted therapies, capmatinib and tepotinib at this time, which can be offered for patients in the metastatic space. But not only that, for patients with MET amplification, meaning that the c-MET is looked at in the patient's tumor tissue at baseline, if they have very high levels of amplification, they can be candidates for a brand new novel antibody drug conjugate called telisumab vedotin, which has just been entered into clinical practice and is really showing how we're changing and opening up a lot of treatment patterns for patients that don't involve explicit chemotherapy options, which is very exciting. Next, we'll see ROS1 fusion. Again, another very rare mutation, not commonly associated with tobacco use, for which we have targeted therapies as well. This is a very rare type of cancer. Less than 1% of patients will have this, but it's important to see it upon diagnosis because immunotherapy may not always be the best treatment option for patients with this mutation. Next is RET fusion, same sort of thing here. We have at least three oral targeted therapies that are approved for patients with this fusion, and we have seen great outcomes with this as well. The last one I'll mention here is one called BRAF. BRAF is another mutation that we can see in non-small cell lung cancer, but also in patients with any type of tumor. And the reason this is important is because we do have a tumor agnostic or pan-tumor approval for a combination of not one, but two targeted therapies targeting a protein called BRAF and a protein that is with it called MEK. And when we combine these targeted therapies together, we see that patients with this mutation tend to have better responses than if we inhibit the derilicate BRAF protein alone. So my take-home point from this slide, which is a whirlwind, as you can see, is that there are so many mutations we can identify in patients with non-small cell lung cancer, among other cancer types as well. And it's so imperative that we perform biomarker testing as well as understand the molecular makeup of a patient's tumor prior to initiating treatment to make sure we're delivering the best care for these patients. I've neglected to mention that this slide is not yet complete. You'll remember from the citation mentioned in Dr. Richter's presentation a few moments ago, this is from 2019. We're already missing some targeted therapies here. There's a brand new one called NRG1 fusion, for which we have a targeted antibody or monoclonal antibody called zenocutuzumab. So very exciting times for patients with this disease. The next thing I want to talk about is immunotherapy. Immunotherapy is offered for the vast majority of patients with non-small cell lung cancer. And as a quick reminder for patients, although most folks on this call will have already received direct-to-consumer advertisements looking at immunotherapy drugs like pembrolizumab or Keytruda, or also Opdivo or nivolumab with Yervoy ipilimumab, because the pharmaceutical companies do blast these on mainstream media today. Essentially, what immunotherapy is doing is using the immune system to target cancer cells and try to block a little handshake that cancer cells mimic with immune cells to say, hey, don't kill me, I'm good. And immunotherapy blocks that to make sure that the immune system is primed to actually go ahead and kill those cancer cells. And what I always explain to patients is when they're on immunotherapy, because the immune system is present from head to toe, they're at risk for inflammation of literally any organ. This is what we call the immunotherapy person that we often study in our medical school training to see what is a possible inflammation that a patient could experience from immunotherapy. And you can see it really can truly involve every organ. So just to kind of point out a couple of very common things we'll often see in the clinic. First thing is rash. We'll often see patients have these rashes. They are thankfully responsive to topical steroids, maybe some antihistamines help with itching, and these usually can go away on the easier side. More worrisome would be endocrine issues, especially those that affect the central nervous system. So here we can see an MRI showing a lot of signal enhancement in the pituitary gland, such that patients with hypopituitarism can have downstream endocrine effects, fatigue, loss of sexual function, loss of bone density, et cetera. All these things can be really regulated by the pituitary gland. And it's important we identify this on the earlier side and give folks back endocrine supplementation or hormone supplementation whenever they need it. Another one is colitis, which can be very worrisome, especially for patients who have new onset diarrhea on immunotherapy. Generally, what we tend to do is make sure that we're ruling out any infections that might have started while patients are on treatment. And then from there, they may need indicated colonoscopy to make sure that they're not having ongoing colitis, which you can see here in this colonoscopic picture, at which time they may need to be considered for anti or immunosuppressants such as steroids or even advanced therapies. And then finally, some rare things that can happen for patients who have an underlying set of autoimmune disease, for which we're always screening patients to make sure that they are indeed candidates for immunotherapy, such that we're not flaring other diseases. One sort of rare thing we can see is a disease called dermatomyositis. This can be seen by this inflammation in the skin, which actually goes down lower into the muscle as well. This needs to be diagnosed by biopsy, and these patients will need to be on steroids. So the take-home point is, even though we're very happy and have seen the improvement in patient outcomes with immunotherapy, they don't come without side effects, and we really need to make sure we're monitoring patients very closely for all of this. This is a kind of typical timeline for a lot of the common, what we call immune-related adverse events or immunotherapy toxicities that we can see. And generally, we're not seeing these immediately. Folks have to have these drugs in their system for at least a few weeks, because we know the half-life of immunotherapy is indeed weeks to months, depending on the drug that we're using. And we use these sort of timelines to understand where patients may be delivering or developing toxicity. You can see really between that week 6 to 8 is critical. We could see several immune therapy toxicities start up at that time. So that's really when we're keeping a very close eye on patients as they initiate their treatment. And with that, I just want to take a quick moment and acknowledge everyone who is present on the call today. Lung Cancer Awareness Month is a very important patient advocacy and patient-oriented month and time for remembrance. And I really want to acknowledge all those who are present on the call who are both battling lung cancer and also researching to make outcomes better for patients. I'm happy to take questions at the end. Thanks so much.
Thank you, Dr. Cariff. Now, George Van Wee. There you are.
Sorry, I was there and then I disappeared. Hi, let me just put my screen up here and we'll get started. Good afternoon to everybody. The thought occurred to me, as these gentlemen were talking over here, and how knowledgeable they are about this and all the things that they're doing to help people. It's just wonderful. It really is absolutely incredible. My job is completely different because my job is kind of to hopefully keep people from even having to meet these guys. We try to get people to do, as Dr. Richter pointed out, to stop smoking before it gets to this point, because it will inevitably get to this point. If it's not lung cancer, it'll be some other kind of cancer, and it causes cancer all over the place. But anyway, I won't elaborate on that because I think we all know that. What I really wanted to talk about here was that this is a very hostile environment when you talk about smoking or any kind of smoking or even vaping, and that's what I want to get into because unfortunately vaping has become popular because number one, it's popular among kids, and number two, it's popular because a lot of medical people say, well, you should vape instead of smoking because it's harm reduction. It's not as bad for you, and that's probably true, but we're going to talk about that a little bit more. Just a quick history. Actually, back in the 1800s, doctors started seeing a lot of lip cancer among smokers, and it was just kind of basically ignored. And of course, then they started seeing lung cancer and other kind of cancers. But people just kept on smoking. And even in the 60s, after the Surgeon General's report came out in 1964 and saying, yes, we have definitely linked it to lung cancer and it's causing all sorts of problems, people just kept smoking, and they still do to this day, although percentages are way down. There's no question about that, and that's good. If you look at this picture, it's like, from the 60s here. I mean, it was so far, it looks like he's got a broken wrist there, and he's laying in bed, and the nurses are actually coming around with, what kind of cigarettes would you like? And people did smoke in hospitals in those days. As crazy as that is, obviously we've come a long way from that. So the tobacco companies used doctors to promote their products. They would say, oh, more doctors smoke Camels than any other cigarette. I don't even know how they would have even determined that unless they went around and asked every doctor that smoked. But at any rate, if they put it that way, then the person sees it and say, well, if doctors are smoking Camels, Camels must be okay and must be good for you, and it must be okay to do it. So I'll just go ahead and I'll do it. And you know what? Oops, went the wrong way. History repeats itself because now we're getting things like, well, more doctors vape than use traditional cigarettes. I don't think you really find a whole lot of doctors that smoke or vape for that matter. But at any rate, they're doing the same thing. They're just using the same thing against you. This is kind of a harm reduction thing. Of course, they vape because they're not as harmful as cigarettes, or so they like to tell us. E-cigarettes, and by the way, just so you know, some people call them vapes, e-cigarettes, ends. They got a lot of different names, but it doesn't really matter. They're all basically the same thing. They come in a lot of different forms, a lot of different shapes, and cost a lot of different amounts of money, but they're all basically the same thing. And the one we know of today was invented by a Chinese pharmacist named Han Leek. I hope I'm pronouncing his name correctly. Back in 2003. And he was a 3-pack a day smoker, and he decided that he was going to make it his mission in life to invent a new device after his father died of lung cancer. And so he did. He created what we now call the e-cigarette. But of course, he became a dual user, meaning that he smokes cigarettes and he uses e-cigarettes, which is kind of the common problem. We get a lot of people that are quitting combustible cigarettes and then they're going to e-cigarettes, and then they end up doing both, or they end up going back to regular cigarettes when they have a problem with their e-cigarette, which is pretty common too. Um, the impact that it's had on my business on helping people quit has been, well, number one, it does change the method of delivery. Now they're getting nicotine, which is considered largely to be the most addictive substance on the planet, and they're getting it in a different form. It's just coming through the e-cigarette, or like it did before with chewing tobacco and stuff like that. It's just incredibly addictive, and the dependence is not addressed at all. It's like you say, okay, go to e-cigarettes. People go to e-cigarettes and you got the same problem. You got the hand to mouth motion, you got people doing it at the same time. The nicotine is keeping them dependent upon it. So the dependence is not addressed at all. All they've done is kind of change the method of delivery. And people are told, oh, well, it's just water vapor, so it's not a big problem. Well, it's becoming a big problem. And first of all, it's not water vapor. It's it's actually an aerosol. I just want to point that out because water vapor, in order for water to become vapor, it has to get boiled at 212 degrees. And if you were to inhale that into your lungs, I don't think it really takes a lot of imagination to know what that would actually do to you. The psychological and emotional impact has changed because people do believe that it's harmless, or at least less harmful. It's become normalized. People kind of accept it. It doesn't smell like regular cigarettes, so other people don't notice it. So they're not kind of getting that social kind of pressure that they were getting before. Um, the harm reduction, again, I'm going to get into that more in a minute. It is not a proven method to quit. In fact, people are less likely to quit that go on to e-cigarettes. If you ask them, they'll tell you, yeah, I quit smoking because now they're vaping, but they're not going to bother to mention that until you press farther on the issue. But at any rate, they think that. And so they think that the harm is done. They think that they're safe now. They can go back. I like this particular little graphic because it's representing the smoker as being dead, really, and the e-smoker is fine because he's smoking something less harmful. People say, do they help people quit? No, they don't. As a matter of fact, as I just said before, they imitate all the same things that smokers do. It's just same thing. It's just a different delivery method. Even the FDA has pointed out that it's not a good way to quit. It doesn't reduce nicotine levels, and as a matter of fact, in a lot of cases, it's been increasing nicotine levels because, of course, a lot of these e-cigarettes are made by the tobacco companies who are well aware that nicotine is the thing that's keeping them in business and has been all along. It's really the only business that they can legally sell something that is this addictive and make a profit doing it. But that's the way it is. So a lot of people say that the Hippocratic Oath says, "Do no harm," which it actually doesn't really say that. It's often attributed to it's obviously it's attributed way back to when Hippocrates said it, but it's not a part of the oath actually. I'm sure the doctors on here could verify that. It's actually in a different work of his called Of the Epidemics. However, it basically is just saying what it was loosely translated from the Latin below, which just says for a doctor's ability and judgment, they will consider the benefit of the patient and abstain from anything that is dangerous. So when you think about the idea of do no harm, it would really be kind of impossible for a doctor to treat somebody without doing any harm if they had to do something like surgery or something else, because obviously you got to cut into the skin and do stuff like that in order to do it. But at any rate, one thing it does not say is do less harm. And unfortunately, that's why vaping is becoming a big problem. The question, but aren't they safer than cigarettes? And I'll say probably. In fact, most likely. In fact, most everything is safer than cigarettes. Cigarettes will inevitably kill you. It's just a question of time. I put this graphic on there because statistically speaking, it's safer to handle rattlesnakes than it is to smoke. So that kind of gives you an idea. As far as the e-cigarettes go, there's over 400 different brands on the market today. They are not very well regulated by the FDA. In fact, they're very lightly regulated. That's supposedly changing, but they take a long time to get anything done, as we know. So we don't have any idea what's in them. I attended a lecture once, which was a part of that lecture was the vice president of the then second largest e-cigarette company on the planet. I don't remember his name actually, but he couldn't tell you all the ingredients that were in his own e-cigarettes. In fact, I'll give him credit for being honest. He came out there and he says, look, I'm not pretending that this is a good way to quit smoking. I'm not pretending this product is safe. I just saw a billion-dollar industry and I wanted a piece of it. So that's why he got into it. Nicotine's addictive and potentially harmful no matter how you ingest it, especially among uh, teenagers and young adults, and they're the people that are really using vapes percentage-wise anyway. Some have exploded. That's not the part of the e-cigarette. Well, it is in a sense, it's part of them using cheap batteries, which of course they do, and the cheap batteries aren't meant to be recharged the way they are being recharged constantly, and they've blown up a lot. And I could show you a bunch of gross pictures of people that have had part of their leg blown off, or people have even died from it, as a matter of fact, part of their face blown off and stuff like that. But you get the idea. Dr. Richter also spoke about chemicals in lung cancer. And these chemicals, a lot of the same chemicals that he mentioned, are in e-cigarettes as well. And of course, they find different ones all the time. Many of them are carcinogenic. Some that he mentioned here, well, I'm not going to read them all. You guys can see that. They're loaded with chemicals, and they keep you addicted, so they don't really care. Some of the heavy metals that are involved, chromium, manganese, nickel, present in e-cigarettes, and I think Dr. Richter mentioned those chemicals as well. Obviously, lung cancer has been linked to chromium and nickel. There's a lot of other problems involved besides lung cancer. Cadmium exposure linked to lung cancer can also harm the kidneys and God knows what else. So far, the known impacts, I say so far because we saw that this thing wasn't even invented until 2003, and it's been on the market even less than that, and not really reached the big part of the markets until we got into the early teens there. So we just don't have that much historical knowledge about it. But so far, we do know that it affects the brain. Um, and in fact, even just nicotine alone affects the brain in developing brains in young adults, cognitive, mental impairments, all sorts of things. I'm not going to get into all of them here. Same thing with head and neck. Again, we're talking about the lungs, bladder, breast. I want to just point out that there is no part of the human body that smoking doesn't affect negatively. Everything in the human body gets negatively affected by smoking. It doesn't really do any good for anything. Heart failure also lining up with e-cigarettes. Increased risks. All sorts of problems there as well. Digestive system. You may remember this. For a while there was a bad problem with people going in. They were using e-cigarettes and they were having a lot of pain in their stomach. They didn't know why, and they went in and they associated that with propylene glycol, which is a chemical that's commonly found and almost always found in e-cigarettes. As a matter of fact, it's a fake smoke chemical that when you go to like a place where they got fake smoke going on stage or whatever, that's what they're using to do that. They also use that a lot of the processing of food. As far as we know, that's pretty well tolerated when it's in with foods. How well tolerated it's going to be in the lungs is another question, and how well tolerated it's going to be when it comes in as smoke or as vapor is another question as well. It was eating away at stomach lining. It's giving a lot of people problems there. Other people, well, it's there's no such thing as secondhand vape, and yes, there is. They're finding more and more along this. Kids that are being around electronic cigarettes are having a lot more of these chemicals found in their body than kids that are not around them. So you can't smell it. You don't usually know what's around, which makes it handy for kids to, especially like in high school, to do it when their teacher's not looking. They take a quick drag. They got these little pens that'll stick right in their pocket. Nobody even knows they're there. They take drags when the teacher turns the other way, so they're vaping and nobody can smell it. So they don't even know that it happened. And it just makes it awful convenient for them. So in summary, our efforts to help people quit has in fact been affected negatively by these things because again, people think they're safe. They think they're harmless and they're not. And I'm sure they're going to find more and more problems with them as time goes on. So it's just good to remember smokeless does not mean safer, and safer does not mean harmless. And again, it's not water vapor, it's a chemical aerosol. Call it what you want, but that's what it is. And the long-term impacts, of course, will just become more and more common, and you're just going to see all sorts of things popping up here or there. So what we do is we try to help people quit before it ever gets to that problem. You've, I'm sure, heard of tobacco-free Florida when the master settlement against the tobacco companies went down in the 90s, and there was like 47 states involved with that, Florida being one of them. They were granted $13.5 billion in this effort, and kudos to them because they established tobacco-free Florida, and the idea was to help people quit. And I say kudos to them because a lot of states didn't. A lot of them took that money and they built football stadiums or did whatever they did with them. But Florida directed it to that. So we're funded by the money won from that lawsuit. And fortunately, it's in the legislature, so it's going to be there for quite a while. We have free evidence-based programs. We have to go through a lot of training to get here. So I don't want you to think that we just kind of make stuff up as we go. The groups are very helpful. It's a very positive sort of thing. People actually find that they really like it. The social support is important. You've seen the advertisements on TV. They say call, click, or come in. I work for the come in part of that. We do live groups. We either do them in a particularly setting like we used to do them at Boca Regional for a long time. And hopefully we will again, but we got to wait for that construction down there to get done because nobody knows where they're going, including me when they go down there. So um, we also did them at Bethesda for quite some time, and we will look forward to doing that again. But in addition to that, because of COVID, we started doing Zoom classes, and we've continued to do that because it's very convenient. It's convenient for people, especially that live like in I don't know, Okeechobee or something like that, where we just don't have a whole lot. We can't offer a lot of live classes because frankly we don't get very many people at them, and it's hard for us to pay facilitators. We're nonprofit, we're very limited. We can't take any money for anything that we do. We are kind of under the thumb of the Department of Health in Florida, so that's kind of where all our funding comes from. Again, we are the group Quit. We also have the Quit line or Web Quit, which are other options for people to use. I appreciate your attention. Here's phone numbers if you want to jot them down or whatever. Uh, and for anybody that happens to want, a copy of this presentation, I'm more than happy to share it with you all. I have all my references back here in case you guys think I was just making up a bunch of stuff. Anyway, that's about it. So unless you guys got some question or whatever, I'm going to call it at that.
Thank you, George. That's always very enlightening, very frightening. We do have one question, but it is for one of the physicians. I don't know if you can see the question. You see it? Someone who has a familial history of lung cancer considered high risk.
Thank you very much for the question. I can take this one. So, indeed, we do find that folks with family history of lung cancer are generally at higher risk than the average population. I want to comment on two things that support that medical understanding now. The first is that there is a rare type of EGFR mutation called T790M that's actually inherited through what we call the germline gene, where if your mother or father biologically has this gene and has passed on to you, you are at a very high risk of having EGFR mutant non-small cell lung cancer, specifically with that T790M mutation. So from that aspect, we have a genetic basis. However, there's also an additional likely genetic, maybe partially environmental basis that we haven't fully been able to understand, but that we have researched on previously that shows that patients with family histories of lung cancer are at risk of having it themselves. Dr. Richter mentioned the National Lung Screening Trial, the NLST, for which we have the approval for low-dose CT scans for lung cancer screening. And indeed, we saw that a lot of patients with family histories were included in that cohort. But if we use other models to look at this, such as the PLCO model, this is another very common NIH-funded study that looked for risk factors for patients with lung cancer. We saw that just the mere fact of having a family history put you at greater than average risk, such that there's actually calls for advocacy to change the USPSTF recommendations from the NLST-based screening to be more inclusive with patients with higher tobacco use. I'm very happy to share that data with anyone that we've published previously as well.
Thank you. Any other comments on that? So thank you, doctors. This was very, very informative. We appreciate all the research that goes into it and the time that you spend with us. And for anyone in the audience, there was a lot of good information today that you may want to review, or if you want to share it with family or friends. Our lectures are recorded, and Lee will be sending out an evaluation to everyone, and we do appreciate your comments and your responses on the evaluation. And at that time, you can ask her if you'd like a copy of the lecture. So I just want to say that we'll have one more lecture in November from our nutrition series. It will be entitled Fueling Your Bones, the link between nutrition and strength. And our dietitian, Katie Lauterbach, will be presenting that. So thank you to our amazing speakers for your time and your expertise. We're very, very grateful. And to everyone who joined us today, have a good afternoon and rest of the week. Bye.
Thank you.